Good afternoon. We come to the September issue of IJCCM, and here we have a very relevant topic on scrub typhus and its association with hemophagocytic lymphohistiocytosis. So let me start off by asking Dr. Pannu, what interested you in taking up this topic?
Hello, everyone. The main background of starting this study was that the scrub typhus patients have a higher mortality despite being treated with the appropriate antibiotics. And in the last 1 decade or so, we have increased awareness regarding scrub typhus in our country. So despite being treated with the appropriate antibiotics, that is doxycycline and azithromycin, we have a significant mortality, which is around 10% in these patients. So recently, we have published a large randomized control trial from India in NEJM on scrub typhus, which includes a combination of treatment, that is doxycycline plus azithromycin versus azithromycin alone and doxycycline alone. And that trial also does not have an improved outcomes with combination treatment. Outcomes in the form of mortality, requirement of mechanical ventilation, duration of hospital stay, duration of ICU stay. There was an increased survival. Overall, the mortality was similar between the three groups. So that was the main basis of doing this study, because we are seeing increasing number of cases, especially in the monsoon season, that is between July to November. So that was the main basis of doing this study, because this is an important complication apart from the other complications like ARDS, acute liver failure, or encephalitis, or DIC, or severe thrombocytopenia. So that was the main background of doing this
study. Sir, Dr. Ashit, Dr. Hegde, you would like to, you have raised this, whether we are overdiagnosing or it's underdiagnosing of HLH by these scores. So would you like to comment about that once again?
Yes, thank you. Of course, let me begin by congratulating you, Dr. Pannu, for winning the best paper for this month. And my main, I mentioned this in my editorial as well, that, you all have used the HS score, which of course is for the diagnosis of HLH in adults. But as you know, that study was done in a Western center and in the original study, there were no patients with tropical infections in that validation study. And even subsequently, the studies that have validated the HS score in adults have had no tropical infections in their cohort. So given that, there's a lot of overlap between the components of the HS score in adults and the prevalent abnormalities in patient tropical diseases, as you all yourself have done in your study, you all had to raise the cutoff much higher, because if you use the original cutoff of 169 or so, then almost 1/3 of your patients qualified as HLH. So you thought you would overdiagnose if you use the traditional cutoff, and therefore you all use a higher cutoff, which probably would mean obviously underdiagnosis because you used a much higher cutoff. So my main question is, do you really think the HS score is applicable to tropical infections? Do we need another study to validate that in tropical infections, or we need a separate score for tropical infections for HLH, diagnosis of HLH in tropical infections?
So the main idea behind using HS score in this study was that the HLS 2004 criteria, which we usually apply to the pediatric population, that is for primary HLS, that includes natural NKT cell activity, as well as soluble interleukin 2 levels, and also bone marrow examination. These investigations are usually not feasible or available in our setup. And HS score, there are studies which say that HS score can be applied in tropical infections like in dengue and malaria. There was one large study published in Clinical Infectious Disease, which is an official journal of IDSA, Infectious Disease Society of America, on dengue, which also used H-score for diagnosing HLH in dengue. So obviously we need to validate this score in tropical infections, but for the time being, because we do not have anything else apart from H-score, the parameters which we use in H-score is crossly readily available apart from the bone marrow examination. Bone marrow examination can also be done on case-to-case basis. So H-score is a handy tool. We have almost all parameters available with us in reasonable cost, and most of the hospitals have facility to perform ferritin, so which is usually available in within 24 to 48 hours. So that's why we use this H-score. In critical illness setting or in ICU setting, there are studies which have used H-score, and they found that a higher cutoff of H-score, that means that 200, is more or less same efficacy or same diagnostic performance as the original HLH 2004 criteria. HLH 2004 criteria is also not validated in the adult secondary HLH. That is also an issue. So for the time being, I think we can use this score until we have more studies on both the diagnostic criteria, that is HLH 2004 criteria, and as well as score specifically in the tropical infections.
My question really was the practical implications of this diagnosis. Now, once you've diagnosed HLH, are you going to start, things like steroids or IVIG only on the basis of an HS 2004 score? I mean, does it matter? Like, suppose somebody, whatever your HS, like in dengue, early dengue, quite often people have a high HS score, but they're pretty well, so we don't do anything. Whereas, patients, so clinically somebody's deteriorating, whatever is HS score, I'm going to think of starting steroids and IVIG if the ferritin is very high. So that's what my editorial mentioned. Does it really matter what the HS score is? Are we going to go by clinical factors, or are we really going to go by an arbitrary HS score?
So the primary treatment for secondary HLH is the treatment for the basic disease. That means if it is associated with dengue or strep typhus or malaria, enteric, the main treatment remains the primary treatment of the disease. That is doxycycline or azithromycin for strep typhus. When should we consider immunomodulatory treatment? That is a difficult question. We do not have any trial or any randomized control studies. So case-to-case basis we can do. Like if the organ failure is persisting despite adequate antibiotics, like new organ failures are increasing, especially neurological. Because in this study also we found that the seizures and neurological features were differentiating secondary HLH with or without secondary HLH strep typhus patient. So in my experience and while doing this study also, we found that if the patient is not improving in the form of response to fever or response to organ dysfunction or developing new organ dysfunctions, like in the form of neurological dysfunctions or worsening ARDS or worsening circulatory failure. So in those cases, in case-to-case basis, we can use immunomodulatory treatment. Now, the type of immunomodulatory treatment is also difficult to define. Like in our setup, it is difficult to give steroid because there are high incidences of secondary infections, secondary bacterial infections in these patients who are admitted in emergency department or who are admitted in ICUs. And IVIG is also not readily available. So right now we do not have that exact definition for immunomodulatory treatment in secondary HLH in tropical acute febrile illness.
Can I ask a question, sir?
Yes, doctor, please.
Sir, or Dr. Pannu, do you think if we repeat this score, like this that you had done in the study was at the beginning of the when they got admitted, right? So yes. Suppose I say that you are suspecting that this patient is going into or has HLH, then maybe at that time you should repeat. So I'll take your opinion on that and maybe ask Dr. Hegde also about this.
So usually in these patients, like in this study, we did not mention it, but usually in patients with secondary HLH, we usually repeat ferritin and other parameters of secondary HLH on daily or alternate day basis. Like we are doing liver function test, fibrinogen and triglyceride, that is readily available. So we can do these investigations on a daily basis, and we can calculate DH score on daily basis, similar to the DIC. When we do DIC parameters on daily basis and see, okay, DIC parameters, DIC is improving or not. Similarly, for secondary HLH also, we can repeat these parameters on daily basis or on alternate basis. Like ferritin is slightly costly than the other parameters, so we can do it on alternate basis. And if we have started treatment like immunomodulatory treatment for secondary HLH, then also we can monitor these parameters. And there are studies which say that if ferritin is decreasing, then there is a response to treatment. Similarly, suppose if you have not started any immunomodulatory treatment and you are giving only antibiotics, you find that there is an elevated H score, then you can also repeat ferritin and other parameters to see that the H score is increasing, and if the patient's clinical scenario is also deteriorating, then in that case you can be more. The decision of starting immunomodulatory treatment can be you can take with more confidence.
So you agree?
No. Yeah, I mean, I more or less agree, but I go really more by clinical deterioration. Clinical deterioration in spite of adequate whatever specific treatment, like you said, and maybe ferritin. So I think things that make me think about HLH in these patients are persistent fever in spite of fever. The fever persists, like you said, neurological alteration, very important point, neurological alteration persisting and worsening liver function and ferritin going up. I mean, I'm just saying, I wouldn't probably do the entire HS score. I think most of us, in theory, use scoring, but in actual bedside, almost never, practically use scoring systems, though for theory and for writing, I think we need that. So I would go by these points: clinical deterioration, especially neurologically, liver function-wise, maybe hemodynamics, persistent fever, and ferritin going up because we don't want to be too late either, nor do we want to overdo the immunomodulatory therapy, but at the same time, we don't want to miss the opportunity of intervening, with either steroids or IVIG, whatever we think is that. Now they say even interleukin-1 antagonist, whatever we use. But I think that's what I would go by. I mean, so persistent fever is and neurological symptoms will probably be my number one, indicators.
Excellent. I think we have really nicely summarized it up. And if you have anything more to add, Dr. Pannu, otherwise we'll close the session.
Ma'am, I think we obviously need future studies. And one of the study which we can plan is to give upfront immunomodulatory treatment in patients with ferritin more than 2,000 or more than 6,000. And because despite giving antibiotics, 10% mortality is significant.
And I think the Southeast Asian region has to lead in this dengue and all these kind of studies. Right. Thank you very much, both Dr. Hegde and Dr. Pannu. And it's been a very informative session. Thank you.
Thank you. Thank you very much.